Welcome everyone to the OzSAGE press conference for Monday, the 8th of November, 2021. My name is Greg Kelly. I'm a paediatric intensive care specialist and OzSAGE member. And I'd like to start by passing to Dr. Kalinda Griffiths for the acknowledgement of country.
Thanks, Greg. Before we begin today, I'd like to acknowledge the traditional custodians of the many lands on which we're meeting. I'm coming to you from Larrakia country in Darwin, upon whose land's sovereignty was never ceded. And I pay my respects to all elders, those of the past, the present, and the future. Greg, I'll keep going with my reporting now as well, and I'll just introduce myself. My name is Dr. Kalinda Griffiths, and I'm an epidemiologist at the Centre for Big Data Research and Health at the University of New South Wales. I am a Yawuru woman, and my family name is Corpus. And my country is in Broome in Western Australia. So to date, there have been over 7,000 Aboriginal and Torres Strait Islander COVID-19 cases. And most of these cases have been in New South Wales with almost 6,000 cases, and almost 1,000 cases have occurred in Victoria. 200 cases have been reported in the ACT. It is a primary remit of the OzSAGE group that no one is left behind. But as Australia begins to open up, it has become apparent that there are people in the population who are missing out. It has been the recommendation of the Aboriginal and Torres Strait Islander OzSAGE working group that 95 to 100% of Aboriginal and Torres Strait Islander people over the age of 12 years need to be fully vaccinated before states and territories open their doors. So currently, 64% of Aboriginal and Torres Strait Islander people over the age of 12 years have received at least one dose. 51% are fully vaccinated. Still, about 20% lower than non-Indigenous people. So in those states that have been impacted the most, we've seen higher rates of vaccination than other jurisdictions, with New South Wales now at 74%, Victoria at 70%, and the ACT at 81% of Aboriginal and Torres Strait Islander people fully vaccinated, which is really good news. The most recent reporting shows that there have been over 700 Aboriginal and Torres Strait Islander cases hospitalised, with 81 people that have been admitted to ICU. 14 Aboriginal people have died, all in New South Wales. So COVID is a disease of the unvaccinated. If it gets into regions and communities with lower vaccination rates and higher risks of transmission, it will spread very fast. In New South Wales particularly, we've witnessed some of the impact that can occur and know that there are devastating consequences due to this disease continuing to spread, particularly through regional and remote Australia. With already stretched healthcare services and limited workforce availability to manage COVID patients in those regions, it's anticipated that things can and will get much worse. This highlights the need to reassess how we respond to outbreaks in Australia. It is apparent that there is a need to better support public health orders through better infrastructure, taking up evidence-based approaches, known to work in regional and remote areas, as well as appropriate governance that ensures the priorities of Aboriginal and Torres Strait Islander people are actually actioned. With lower vaccination rates and greater impact from COVID, it's therefore very important that attention, resources, and innovative approaches to supporting Aboriginal and Torres Strait Islander people and communities is there, particularly to those services already doing the hard yards. Governments must support medical experts, Aboriginal medical services, communities, and those people working on the ground to ensure that Aboriginal and Torres Strait Islander people have the things that they need to protect themselves and each other, to ensure that no one is left behind. In order to assess the needs of different communities and different regions, there is a requirement for information on service availability and impact. Despite the recommendations and ongoing call for accurate and appropriate data, there is still a clear need to improve the transparency, the quality, as well as the availability of disaggregated data. That is, data broken down and displayed by population groups and regions. These data are important because they let us know who needs what where. There are still many people in the general population who are not vaccinated, and an even higher proportion of Aboriginal and Torres Strait Islander people unvaccinated, which means that this matter is urgent. We recommend that there is an assessment of each jurisdiction in the decision-making regarding the approach taken to support those populations at higher risk and how this impacts outbreaks. At this point, it should also include the plan for providing booster shots to Aboriginal and Torres Strait Islander people. We recommend that the publication of Aboriginal and Torres Strait Islander vaccination rates is presented by state and territory local government areas, and it's released more frequently. The purpose of the document is to provide information to those who can help. Without this up-to-date information, this help is lagging as well. We also encourage those Aboriginal and Torres Strait Islander people who have not yet been vaccinated to do so, and that any concerns regarding the vaccinations can be discussed with an Aboriginal community-controlled health service or health provider. And so as states and territories move towards more relaxed restrictions and Australia plans on opening up, everyone needs to know that there are people being left behind. There is a responsibility of governments and individuals to support and protect those priority populations that need additional assistance to ensure equity within this nation. I'll leave it there.
Thanks very much, Kalinda. I've got to say it is pretty concerning that despite Aboriginal and Torres Strait Islander people being a priority population for our vaccine rollout, we've in fact, rather than closing the gap, we've actually managed to recreate the gap that we have with many other health delivery issues in Australia, where we have a 20-point lower vaccination rate in those populations than the general Australian population. And that really is one of the other things that OzSAGE is really pushing, is the idea that we have averages are important, but it's very important that we have disaggregated data. So we see that what happens with vulnerable groups. We've spoken about Aboriginal and Torres Strait Islander people. Professor Igor Segalov will soon be talking about another very vulnerable group, who are patients with cancer and other immune conditions. And so it's vital that we know that while 80% of a state may be populated, that if that's only 30% in a regional town, or 70% in the Aboriginal and Torres Strait Islander population, that those differences really matter. So for the rest of the conference, I'm going to present the stats and deaths at home for the data for the rest of Australia, or for the whole of Australia rather. And then, as I mentioned, Professor Segalov will be talking about the new OzSAGE release of information about patients with cancer and other conditions. Before we go on, I'd like to remind you that there is also an OzSAGE seminar this evening between 5 and 6, co-hosted with the University of Wollongong. And talking, the title is Unlocking Fortress Australia, and it's really outlining a roadmap for what the next year is going to look like as Australia clearly moves into this next stage of the pandemic. All right, Tom, are you able to put up my slides for the stats and deaths at home? Great. All right, I'll just maximize this. Great. All right. So this is actually the data for the last 2 weeks, because we didn't have a press conference last week due to the Melbourne Cup. And in the last 2 weeks, there have been 23,805 reported community cases around the country. Quite a remarkable stat in that 53% of those cases are below 30 years of age. So as Kalinda mentioned, COVID is very much a disease of the unvaccinated, and it is now the younger age groups that are representing more and more of our unvaccinated population. And so given that the vaccination is only available for patients 12 and above, or for people 12 and above rather, that under 12 age group is now our single largest unvaccinated population. Around the country, 81% of those over 16 are fully vaccinated. As I mentioned earlier, though, that does conceal some important differences. And OzSAGE is really requesting state and federal governments of all levels to increase the transparency and the detail of the data that they make available, so that we can actually really target our interventions and our vaccine drives to where it's really needed. Children between the ages of 12 and 15 have only recently been eligible for vaccination, as we all know. However, they are really turning out in droves to get vaccinated, and 52% of that population is now fully vaccinated, which is fantastic, and that's rising fast. Can we have the next slide, please? Sadly, there's been 53 active outbreaks in aged care facilities across Australia, 123 cases in residents, 54 in staff, and 23 new deaths, we're sorry to report. School outbreaks continue to be a problem. So in the ACT alone, there's been 14 schools listed as exposure sites this week. There was one large outbreak with 40 cases. There's been 20 schools in Victoria which have reported at least one case. And in the last 3 weeks in New South Wales alone, there's been quite an extraordinary 118 school closures. So really highlighting the importance of in-school mitigation. We mentioned that that population under 12 is the single largest unvaccinated population, and schools are the place where they get together. So it is really important that we focus on in-school mitigations to enhance the safety for both students, teachers and their families. There has been recent announcements about twice a week antigen testing in schools and to reduce the amount of students missing school. We're still waiting on some details about that. It's still a little bit unclear about how that's going to play out. Can we have the next slide, please? So both the so across the states with the outbreaks at the moment, which are New South Wales, Victoria and the ACT, obviously rate of growth is slowing, which is fantastic news. And that is despite restrictions being relaxed in the last couple of weeks. And that's probably driven by the increasing vaccination rates that we've seen. Next slide, please. In the last 2 weeks, there's been 197 deaths, so still a substantial number of deaths. And 5 of those have occurred in people in their 30s. So this this is a disease that does not spare young and otherwise healthy people, even though they are less at risk than older people and those with medical conditions. In terms of the stats for state by state, so New South Wales has 264 hospitalised, 48 in ICU, 20 on ventilators. Victoria, a lot of hospitalisations, 556, 91 in ICU, 54 on ventilators. And also, this is not in this table, but we've seen quite extraordinary numbers of patients on ECMO, so which is the highest level of life support available. So as at yesterday, the Alfred, which is the largest ECMO service in Australia, has 17 people on ECMO, which is full heart and lung bypass support, the highest level of life support you can have. That's easily the largest number of patients they've ever had on ECMO. And in the last 2 months, they've done a full 1 year's worth of ECMO support. So that's a load on the health system that isn't captured necessarily in data all the time, but represents an extraordinary load. The ACT just 1 each hospitalised, ICU and ventilation. And fortunately, the other states, the states without any COVID at the moment, are all recording very happy zeros. But in total, around the country, that represents, as you can see, 821 hospitalised, 140 in ICU and 75 ventilated. Again, clearly with a preponderance for the older age group there, you can see the 70 plus. Next slide, please, if there is one. Great, all right. So now I'm going to pass over to Professor Igor Segalov, who is going to talk us through the new OzSAGE document regarding patients with cancer and other conditions. Oh, I think you're mute, Eva, which is not common.
Thank you very much, Greg. And on behalf of the Cancer and Immunosuppression Working Group of OzSAGE, I present this paper looking at adults and children with solid tumour and blood cancers and people with significant immunosuppression. The purpose of the document is to give broad advice, not individual patient advice, and to cover people who have impaired immune system due to cancer or its treatment, or due to immune disease or its treatment. This acknowledges there are many other medically vulnerable groups. They're not specifically addressed in this advice. Specific advice is needed for this group due to the mounting evidence that COVID-19 vaccines may be less effective in these patients, and that these patients become more vulnerable as the community opens up. They become more vulnerable in terms of still having a high risk if they catch COVID of a very poor outcome, but also they become vulnerable in terms of being socially isolated or different or removed from the community because of their impairment of their immune system and their concerns about COVID. So as a background, almost 150,000 Australians were diagnosed with cancer in 2020, and 1 in 2 men and women in Australia will be diagnosed within their lifetime. Fortunately, many of these cancers are very curable. Autoimmune disease is estimated to affect around 5% of Australians. Now, impairment of the immune system can wax and wane over time, can depend on treatment, can depend on the status of the disease causing immune suppression. So there is no one size fits all, but we do know these patients have poorer outcome. And in addition, there is evidence to show that if these patients are infected with COVID-19, the infection lasts longer, there's more prolonged viral shedding, and there is evidence that this predisposes to the evolution of virus. So it's not a situation that we want to encourage. Even after 2 doses of COVID-19 vaccination, patients with cancer, on chemotherapy and other causes of immune suppression are at higher risk of hospitalisation and death, and in fact constitute about 44% of breakthrough infections admitted to intensive care in the US now after double dose vaccine, even though it's less than 3% of the adult population. Now, we were very fortunate that ATAGI on the 7th of October recommended a 3rd vaccine dose, what's been called a 3rd priming dose. This is not a booster. This is to get this group of patients to the level of antibody response or response to the vaccine that we would expect after 2 doses in people without an immune suppressive condition. However, many patients, we don't know exactly how many, but certainly appears to be a significant number of patients with cancer who've been able to be vaccinated since very early on in the Australian rollout and remain unvaccinated. Each of the medical and allied health societies have got specific guidelines, and there's been other flow-on effect from the heavy impact of COVID-19 burden on provision of health to patients with severe illness like cancer. We know there's been decreased rates of cancer screening. This has meant that patients are more advanced in their diagnosis and will need more treatment. And we have data from Victoria as well as internationally. So the key problems are the impact from delaying life-saving surgeries, the impact on our health system, the fear of it being overrun and being stretched, and the impact on all sorts of healthcare workers that interact with these patients with cancer and other severe immune suppressive diseases. We recommend a vaccine and vaccine plus strategy at OzSAGE, and we're very grateful that this 3rd immune priming dose has become available. The US Centre for Disease Control has recommended a 4th dose at 6 months for patients with moderately and severely immunocompromised conditions, and we would like to see work on this 4th booster being considered in Australia. We know that patients who have compromised immune systems should be rapidly considered for use of anti-COVID monoclonal antibodies if they do test positive for COVID. We're very concerned about children with cancer aged 5 to 11 who are being exposed to COVID in the communities, at school. And again, I refer to patients like this really being excluded from society without access to vaccine. We call for all staff in contact with immune suppressed patients to be fully vaccinated, including boosters at 6 months, and all day centres, wards for patients with cancer having uniform policies for vaccine plus, including N95 with fit testing. We have many patients being exposed to multiple COVID tests, PCR tests, due to them attending cancer day centres frequently, and we call for this group to have availability for rapid antigen testing, both for patients and staff. We're also concerned about schools and workplaces attended by people with immune suppression, and these should be prioritised for safety upgrades as per our OzSAGE guidelines, including safe air in the workplace. We recommend patients with immune suppression are offered flexible study and work conditions. And only this morning I saw a patient who's been really forced to return to work in a school after 2 vaccines. She's not yet eligible for her 3rd vaccine. And really, we need to do better for these patients on chemotherapy and assist them as part of our community. We recommend patients who are immune suppressed wear masks even after vaccination in high-risk settings and maintain social distancing. We call for special funding and fast tracking of studies studying the vaccine response in Australian immunocompromised patients. In maintaining essential service delivery, we recognise there are a number of very sophisticated private cancer care providers who may have spare capacity to provide all aspects of cancer care, and we call for comprehensive cancer plans to rapidly activate this integration if needed. And this would involve statewide coordination. We also care for hospital systems, also encourage hospital systems to separate patients with cancer and severe immunocompromised away from COVID wards. And we've heard instances where, in fact, patients have been with COVID, actual COVID, have been placed in close proximity to cancer wards. And this makes no sense and does not stick to our mantra of leaving no one behind and protecting our most vulnerable. So there is more detail in our document, but we really call for rapid education campaigns amongst the general community, GPs, surgeons and others to really understand the nuances of vaccine and vaccine plus within the immunosuppressed population. We call for engagement of the clinicians in formulating guidelines such as ATAGI. We know there was an update on the 2nd of November clarifying the previous information about who can receive a booster. And patients should be involved in these decisions, patient support groups, cancer councils, other patient advocacies and experts. We call for a provision of hotlines, phone hotlines for both patients and medical and allied health and nursing staff so that appropriate nuanced information can be given, because not all patients with cancer have the same, or immune suppressive conditions have the same risk. And even for one patient, that risk will vary over time. Thank you.
Thank you, Eva. I've actually looked after quite a few child cancer patients in my career, and I appreciate how incredibly complex cancer care is, involving so many different specialties, taking so many months or often years, and how vulnerable those patients are. So I think this is incredibly important work. We have two questions from the chat. Please send through more if you have it. So the first question is about the missing cancer diagnoses from the first wave. And so the person had said that they'd heard about a stat of 3,000 missing cancer patients before wave 1, expecting this to be worse after wave 2. What does the cancer care community think about this? Is this a worry for you?
Yes, indeed. It's a huge worry for us because the cancer won't go away. And so what it really means is the patients will present later with more advanced cancers and require more care from the healthcare system. Some patients who may not have required, for example, chemotherapy, may require chemotherapy. So I think it's very important that our cancer prevention and screening continues, and that we have a plan to catch up on high risk procedures like colonoscopies and some of the elective surgeries.
Yeah. The second question was about, and you did touch on this a little bit, but can you just talk through what you are telling your high-risk patients who might be inclined to sort of isolate themselves at home as the community opens up? Is that a choice cancer patients have to make between being safe and being isolated, or is there ways that they can be in the community and be protected better?
Certainly, we don't want to isolate people more than they can, more than they need to be, but we need to also keep people safe. So the vaccines plus strategy is absolutely critical. We need to make sure people have been vaccinated. There are still some unvaccinated patients, even on having cancer treatment, and we need to make sure patients have all had their third dose. We need to make sure they're wearing masks in high-risk outdoor and indoor conditions and maintaining social distancing. And it's particularly hard for adolescents with cancer who already have a big impact on their social life. And it's particularly hard for patients with cancer on chemotherapy who are being asked to go back into workplaces where the air may not be safe.
Thanks, Eva. And so can I just get you to follow up on that point? You mentioned that there are still some cancer patients who haven't been vaccinated. I find that extraordinary given they were meant to be the absolute highest priority group. Can you talk through the reasons behind that a little bit? Is that lack of access or lack of opportunity?
There is a mixed group there. Cancer patients, there was no specific information until quite late for cancer patients, and that's why we're calling for this hotline. So some patients remain scared, and in fact, we've done some research, and I can sort of, the results have not yet been published, but it really breaks people into two groups: people who are frightened that the vaccine will impact on them and their treatment and get in the way of their cancer treatment, and that's their number one priority. And on the other hand, people who very much want to have the vaccine so that their treatment is not disrupted. There are some categories of patients, like people who have had bone marrow transplants, where, are very rare, but where vaccination is not recommended for a certain period of time, but as soon as they become eligible, they will be vaccinated. So it's more, again, about hesitancy. There is some giving of advice, maybe that out of a lack of specific knowledge from don't have vaccine, it's not safe in chemo, or wait till you finish your chemo. This is not true, and I would recommend discussions be made, and there are documents, there's a lot of resources if you can, but we need to make them very publicly visible.
Yeah, great, thank you for that. Now, Kalinda, there's actually 3 questions for you. I will just rewind to the first one. They're all very good ones, actually. All right, so the first question is for Kalinda. Do we expect that people in Aboriginal communities will have more cancer and poorer outcomes because of COVID?
So Aboriginal and Torres Strait Islander people already have poorer health outcomes due to cancer. And so similar to the discussion that has been had by Eva, Aboriginal people are less likely to go in and get an early diagnosis. They're also less likely to travel for treatment as well, which results in worse, outcomes for them. generally. So if we add COVID into the mix into this, of course, yes, this is going to be a compounding, intersecting issue. And so, you know, often I think Aboriginal and Torres Strait Islander people have been used to juggling multi-morbidities. However, I think that this is quite a new space to be in. And so there has been recommendations for people to go and get vaccinated, and ultimately, you know, the community controlled health organisations have been going around to communities to ensure that that plays out the way that it should. So hopefully with that, I guess, closer contact with Aboriginal and Torres Strait Islander communities, there are discussions happening with those people who have cancer. And to be clear as well, you know, cancer is the second biggest killer at the moment. It's about to be the biggest killer for Aboriginal and Torres Strait Islander people in Australia as well. So this is a real issue in terms of, you know, outcomes and ensuring support for that. So yes, it will. Yeah,
and I certainly from my couple of years working in the Northern Territory and seeing that a lot of cancer presentation in Aboriginal people is extraordinarily late and untreatable by that point. I would be also very worried that would worsen that. I'm very, very worried.
Yes.
Second question, Kalinda, for you is really a question about a thoughtful question about what's happening in PNG. From what I remember, PNG only has about 4% vaccination rate, and the vaccine rollout there is extremely slow. And there's a question about whether that is expected to put Aboriginal people in Northern Australia and Torres Strait Islanders in the Torres Strait at risk from obviously the close proximity to PNG.
Yeah, so with Queensland as a whole approaching 80%, I guess, first dose vaccination coverage. And there are plans in place aiming for a border opening in mid-December. There are concerns rising in the Torres Strait Island and also the Northern Peninsula area at the tip of Cape York, whose immunisation rates, they remain significantly lower than that of the general population, and that's for many reasons. But the Torres Strait and Cape Hospital and the health services have organised and delivered first and second dose vaccination clinics at MPA, and on all of the islands of the region, with further clinics started on the 1st of November. And just some numbers there that were delivered to me actually quite timely just before this presser. So these efforts plus those of 2 local pharmacies have delivered 21,500 doses to the eligible island population aged 12 and over, achieving 56% full coverage across the 17 island communities as of October 31st. 36% in the Northern Peninsula and 45% in Cape York communities. Yep. And so the question is around the concern for the border with PNG, and the cross-border family and cultural visits have been prohibited, and the waterways are currently closely watched by island communities and heavily patrolled by the Australian Border Security Services. And I think the biggest issue here is that this border crossing is causing a humanitarian crisis, and this is due to the vaccination rates being very low. And I guess that these communities have been proud of their role in protecting the mainland from the incursion of some of those, you know, bio issues that come across the border there. And Cynthia Louis stated that in the Taurus News that this is far from sufficient to protect the region, and it also urged communities to come together and encourage each other to do better to protect each other as well. So there has been quite a bit of consideration and commentary on this, and again, I guess the focus point here has been around getting as many people vaccinated in the top end of Queensland as possible, and that's been the focal point.
Yeah, thanks. And it does really highlight the point as well that global vaccine equity is a tremendously important issue, and that even though we could get everyone in Australia triple vaxxed if our neighbours, or in fact anywhere in the world, is under vaccinated, that is really an opportunity for new variants to emerge. And we might be, perfectly placed and protected against Delta. But if a new, more aggressive variant emerges, we could all be at risk again. So until everyone is safe, no one is safe. And that very much reflects the OzSAGE principle of no one left behind.
Yeah.
Kalinda, just a follow-up question to that, and then there is some more for you, and there's one for which I can answer as well. But a related question, do we expect that people in Group 1A, so Aboriginal people, will have priority boosters as well?
Yeah, so booster shots follow on the same route as, or same timeline. So there's a estimate that, or a discussion that if you're in the first group and you got your vaccine, you have to wait 6 months for your second vaccine to get your booster shot. So even if you are in that priority group, if you were delayed in getting that second vaccine, you still have to wait out that 6 months. And so it's that real issue around having a need to have people have their boosters. But if people haven't had that time frame between, which is around the safety of that booster, then that's a concern as well. So we're going to just have to wait. If you got it late, you're going to have your booster late as well.
Although sadly, many Indigenous people do have quite serious disease, including kidney disease, and so some will be eligible for the third priming dose, and we need to really ensure that all patients eligible for that, including our Indigenous patients, get that as early as the 2 months.
Yeah,
that's great to know, Eva.
Yeah, and there's a question from Emily Burke. Hi, Emily. Which I'll just read through, but it says, on the issue of vaccination of young children, the Prime Minister says that TGA and ATAGI are yet to make a decision on this. Jab is unlikely before Christmas. How do you explain the apparent split in the medical community over the risks posed by the virus itself and the vaccine's possible adverse effects? Is there an objective way to weigh up the risks of the virus and the vaccine for young kids in Australia? So very thoughtful question, which I can start on, and then if any of the other panelists want to add, they can. So look, there is an apparent controversy about COVID and children, which I am going to name. I think that perhaps it does come down somewhat to presentation and style rather than the facts, because the facts are what they are, and it also comes down to perspective. So it can be somewhat confusing to compare COVID in children to COVID in adults. Because we do know that children are less at risk than adults from COVID, but they are also less at risk from everything else. So only 2% of deaths overall occur in children. Children don't get sick or die very much from anything, from COVID or from anything else. And so the US is a really good example of this. So the US has now had 700,000 people die from COVID. 700 of those have been children. And so there are some people who say, well, only 1 in 1,000 deaths from COVID in the US have been in children. Therefore, COVID is not a problem in children. And that logic seems attractive, but it conceals two truths. The first is that 700 children is still a lot of children. The other is that has made COVID the 6th or 7th leading cause of death of children in the United States during the pandemic, because children rarely die from anything. And so some other more, some local examples in Australia. So each year about 30 Australian children die from road traffic accidents, and about the same number die from drowning. These are tiny numbers and across the whole country. And we have huge programs to keep those numbers low as possible. So yes, COVID is less severe in children than adults, but it can still cause serious illness and even death. Fortunately, it's something we haven't seen very much in Australia. In terms of when the vaccine may or become approved, the FDA has issued emergency authorization for use in those younger age groups, the 5 to 11 in the US based on a study of about 3,000 kids, or about 1,500 got the vaccine. The Australian regulators have indicated that they don't think that's enough information, which is not an unreasonable position, because we do have a very prudent and trusted vaccination system in Australia. The sheer number of people that have turned out to get vaccinated shows that Australians trust the system. There are now 28 million American children who are eligible for the vaccine, and so we should get those extra data extremely quickly. It does seem likely that a decision will be delayed until sort of late this year, early next year. And as long as the decision is, or approval is not delayed much beyond that, I think that's okay. I think it should be done certainly as expeditiously as possible. And we should do all that we can to protect children, families, and teachers in the meantime. So there are things like safe indoor air, masks in school places, or anywhere where children gather. And we've identified that it's the single largest unvaccinated group, as well as making sure that all the adults around the children are vaccinated. And with those measures, we hope that we can protect children while waiting for the vaccine approval that is very likely to come.
And if I can please jump in there, we would like much more rapid approval for children with cancer or severe immunocompromised conditions. We'd like that now. These children are very vulnerable. It's got a huge impact on them being unvaccinated, and that's a matter of great importance.
Yeah, and I would absolutely endorse that, just as we had earlier approval in the 12 to 15 age group for children with cancer and other pre-existing conditions.
And I'll jump in as well, Greg. Aboriginal and Torres Strait Islander people's populations are much younger than the general population as well. So we've got a lot of kids in that group. And so the importance is to make sure that, you know, we have that protection there for those kids. And additionally as well, you know, there are high rates of pre-existing conditions within children, Aboriginal and Torres Strait Islander children as well. And so there are a couple of reasons to make sure that that goes forward as fast as possible.
Yep, completely agree with that. I think there's compelling reasons to approve the vaccine much earlier in those very important subgroups. And again, this comes down to the fact that, you know, the population is not homogenous, is not an average. It's very important that we both have data and look at the subgroups within our population. So Kalinda, you're very popular today. There's some more questions for you. So this is from, Marie McInerney. I have a number of questions for Kalinda. Are you able to provide any more detail regarding the need to assess how we respond to outbreaks, who should do the assessment of each jurisdiction, and any advice on the surge vaccination program plan?
I think it's pretty clear from the numbers that even though there has been policy development to, I guess, provide information for populations that need assistance, subpopulations. This includes, you know, people with disability, Aboriginal and Torres Strait Islander people, and other groups as well. There's been quite a big disconnect in regards to the application. We've heard that, you know, even within the cancer group, who were in the first group to be vaccinated, you know, there was a lag time in that information being rolled out. It was the same for Aboriginal and Torres Strait Islander people. There was a lag time in the information and the process to be implemented on the ground. And so what this means is that there's a disjointedness there and a disconnect. This needs some sort of assessment. I think that it would be good to have an external assessment done by someone outside of the government, supported by the government. Basically, the role is to improve systems. The aim of the game here is to make sure that all people in Australia are protected from COVID. And if our systems, processes, services aren't doing that job well, then whatever assessment's done to describe that, I think is going to assist in making sure that things are better into the future. So I don't have the exact answer for you, Murray, but I think, yeah, this is something that it quite obviously hasn't worked the way that it was put on paper to work. Yeah.
Great. All right. That is, it's got to the end of all the questions in the chat. So if anyone has a question, now is the time to ask. Otherwise, we will wrap up. There's been some fantastic questions so far. Great. All right. Well, thank you once again for your time and for joining us. Tom, are you able to just put up the slide about the event tonight, please? Or Iman, rather. All right, so we'll wrap up there. Thank you very much for joining us. Just like to remind you that there is an OzSAGE webinar tonight, so co-hosted with the University of Wollongong with some of our really insightful, thoughtful people trying to chart what the next 12 months is going to look like for Australia. Obviously, things are changing. The pandemic is far from over. And as we move towards opening the state borders, opening the international borders, we're going to have a whole new set of challenges. And I can very much say that the people on this panel will have some really useful insights about what that might look like for everyone. And I can strongly recommend I'll be there. Thanks once again for your time, and goodbye, everyone.